This video presentation extends and completes the earlier presentation on the development of the embryonic gut tube by addressing the development of accessory organs that support the digestive process and the development of the spleen. This list of learning objectives will guide your learning of the content of this presentation. You should recall this slide, which served as a roadmap in our discussion of the development of the gut tube. Our focus during this presentation will be on accessory organ derivatives of the foregut and development of the spleen. Development of the spleen and accessory organs of digestion requires revisiting mesenteries suspending the embryonic foregut, namely the dorsal and ventral mesenteries. During the process of rotation and development of these structures within these mesenteries, names of things change, which creates a conceptual challenge for learners. We will go slow and use several different views and illustrations to help create a three-dimensional picture of what is happening. Much of this will make more sense once you get into the cadaver lab and see the adult relationships of these structures. We will begin with the development of the spleen because it is a bit easier and use these transverse images to aid our discussion. Note that their orientation are as if you were looking down on the cross-section and not upward as in the case of a CT scan. I've labeled left, right, anterior, and posterior for your orientation. The spleen is a vascular lymphoid organ that arises from mesenchyme within the two leaves of the dorsal mesogastrium near the posterior abdominal wall. The dorsal mesogastrium is a portion of the dorsal mesentery that connects the posterior border of the stomach, that is the future greater curvature of the stomach, to the posterior abdominal wall. The spleen is not a gut tube derivative. When the stomach rotates 90 degrees clockwise as seen cranially around its longitudinal axis, the posterior border attached to the dorsal mesogastrium and containing the spleen swings to the left. A portion of the dorsal mesogastrium between the body wall peritoneum and spleen fuse in the region of the left kidney to form the lieno-renal ligament or spleno-renal ligament. The word lieno is another term meaning spleen. The spleen remains intraperitoneal. The portion of the dorsal mesogastrium between the spleen and greater curvature of the stomach becomes the gastrolienal or gastrosplenic ligament. Again, you will see these ligaments in the cadaver lab. With final rotation of the stomach, the dorsal mesogastrium continues to grow downward from the greater curvature of the stomach as a double-layered sheet which drapes over the transverse colon and small intestines like an apron. This apron of mesentery is called the greater omentum and is nicely shown in the top illustration and in the sagittal view in the lower right illustration. Later, the anterior and posterior folds of the greater omentum fuse to form a single sheet, and the posterior layer of it fuses with the mesentery of the transverse colon, also known as the transverse mesocolon. Again, you will readily see this relationship in the dissection lab. When the stomach rotates 90 degrees clockwise, carrying the dorsal mesogastrium with it, a space is created posterior to the stomach called the omental bursa or lesser peritoneal sac. This space is indicated by asterisks in the lower left illustration. On this slide of a sagittal view of the foregut and ventral mesentery, we revisit and expand on the development of the ventral mesentery. The ventral mesentery or ventral mesogastrium is a thin double-layered membrane that connects the lesser curvature of the stomach, the developing liver and biliary system, and first part of the duodenum to the anterior abdominal wall. It is derived from the septum transversum, as you will see in illustrations on the next two slides. This mesentery rotates to the right when the stomach rotates and consists of different parts, a lesser omentum and the falciform ligament. The lesser omentum is that part which extends from the hilum of the liver or the undersurface of the liver to the lesser curvature of the stomach and the first part of the duodenum. It consists of two peritoneal ligaments. The hepatogastric ligament extends from the liver to the lesser curvature of the stomach. The hepatoduodenal ligament extends from the liver to the first part of the duodenum. Its free edge marks the opening of the epiploic or omental foramen, or foramen of Winslow, and marks a communication between the lesser peritoneal sac and the greater peritoneal sac. We will see this more clearly in a later slide of these structures as they appear in the laboratory. The falciform ligament attaches the liver to the anterior abdominal wall. The left umbilical vein passes in the free lower border of this ligament and carries oxygenated blood from the umbilical cord to the liver and embryo and later the fetus. This vein degenerates after birth to a fibrous cord called the ligamentum teres hepatis, or round ligament of the liver. The sagittal views on this slide depict the development of the liver. The primordium of the liver arises as the hepatic diverticulum or liver bud, an endodermal outgrowth of the proximal portion of the duodenum that rapidly grows during the 4th week into the inferior region of the septum transversum. The septum transversum over time thins out as the ventral mesentery. The hepatic diverticulum divides into 2 parts, a larger cranial part representing the primordium of the liver, and a smaller caudal part representing the primordium of the gallbladder. The stalk distal to the primordium of the liver narrows as the common hepatic duct. The liver grows rapidly between the 5th and 10th weeks and largely fills the abdominal cavity, causing the midgut to herniate into the umbilical cord. The liver is a major hemopoietic organ early in development. The hepatic diverticulum gives rise to the primitive hepatocytes, or the liver cells, and bile formation begins during the 12th week. On this slide, we can see that the liver subsequently grows between the 2 layers of the ventral mesentery, causing them to separate and enclose most of the surface of the liver as the visceral peritoneum, except at its cranial end, where it contacts the septum transversum, which, recall, becomes the future central tendon of the diaphragm. In this location, the liver is devoid of peritoneum, and this surface is called the bare area of the liver. The peritoneal reflection encircling the bare area onto the inferior surface of the diaphragm is called the coronary ligament. We now move on to discuss the smaller bud from the hepatic diverticulum that forms the gallbladder and cystic duct. The gallbladder arises from the smaller caudal part of the hepatic diverticulum, and the stalk of this part becomes the cystic duct. The stalk connecting the common hepatic and cystic ducts to the duodenum becomes the common bile duct. Bile enters the duodenum after the 13th week and gives the meconium, or the fetal feces, a dark green color. The next 2 slides describe the development of the pancreas. The pancreas arises from 2 endodermal outgrowths of the caudal foregut or proximal portion of the duodenum, a ventral pancreatic bud and a dorsal pancreatic bud. These can be seen in the sagittal views above and in the transverse views below. The ventral pancreatic bud, the smaller of the 2 buds, develops near the entrance of the bile duct into the duodenum. Rotation of the duodenum 90 degrees clockwise causes this bud to fuse with the dorsal bud. The ventral bud forms the uncinate process and part of the head of the pancreas. The dorsal pancreatic bud, the larger of the pancreatic buds, emerges from the dorsal surface of the foregut and forms the remaining part of the head, body, and tail of the pancreas. This slide describes the fates of the duct systems within the ventral and dorsal pancreatic buds. The main pancreatic duct is formed by the union of the distal 2/3 of the dorsal pancreatic duct with the ventral pancreatic duct. The proximal 1/3 of the dorsal pancreatic duct often degenerates or regresses, but may persist as an accessory pancreatic duct that opens into the duodenum via the minor duodenal papilla. Rotation of the duodenum brings the common bile duct into proximity with the main pancreatic duct. These ducts coalesce to form a single ductal swelling called the hepatopancreatic ampulla fater, which opens into the proximal duodenum at the major duodenal papilla. The major duodenal papilla is also called the hepatopancreatic papilla. The major duodenal papilla is located about 2 centimeters inferior to the minor duodenal papilla if the accessory pancreatic duct persists. You will search for these in the dissection lab. This slide wraps up the remaining embryologic details I wish to convey and relates several of these to the adult configuration you are likely to encounter in the dissection lab. Recall that with the rotation of the duodenum and stomach and the return of the midgut loop into the abdomen, most of the duodenum, except its first part, and the pancreas get pressed against the posterior abdominal wall. Their mesentery fuses with the parietal peritoneum of the abdominal wall, and these structures become secondarily retroperitoneal. Only their anterior surfaces are covered by peritoneum. We also mentioned that during rotation in the stomach and dorsal mesogastrium, that a small space is created behind the stomach and lesser omentum called the omental bursa, or lesser peritoneal sac. This is indicated by the asterisk in the upper right illustration. This lesser sac communicates with the greater peritoneal sac, which is the large peritoneal space the rest of the abdominal viscera moves within. These two sacs communicate via a single passageway called the epiploic or omental foramen, or foramen of Winslow. The epiploic foramen is bounded anteriorly by the hepatoduodenal ligament, which forms the free edge of the lesser omentum. In lab, you will place your index finger behind this ligament and then press your thumb across this ligament to palpate the portal triad contained within the hepatoduodenal ligament. This triad includes the portal vein, hepatic artery, and bile ducts. This slide depicts a developmental anomaly of the pancreas called annular pancreas. This is a rather rare disorder that occurs should the ventral pancreatic bud either split into two lobes, one passing behind the duodenum and the other passing in front of it, or if there is failure of the ventral pancreatic bud to rotate with the duodenum. In both circumstances, a ring of pancreatic tissue is created around the duodenum, causing duodenal obstruction. This requires surgical intervention. This ends our discussion of the development of the accessory organs of digestion and the spleen, and completes some remaining details concerning the ventral mesentery. Much of this presentation and that preceding it on the development of the gut tube has ready application to an understanding of the organization and relationships of abdominal viscera you will see in your dissections. Be patient, and it will come together. I wish you well with your studies.